Thank you, Fultondale Fire and Rescue, for having us. We're at their training center under their admin building. This is super nice. Great air conditioning and good stuff. So super appreciate it. We got one of our senior residents today, Dr. G, talking, and also Dr. Saeed, one of our EMS fellows. We'll also today, after we get through with our lectures at 11, we'll do some free food. If you're in the area, please come by. And then we have the pediatric coaches team, and that is the pediatric ER group that goes around the state and does training with simulation. So come out if you're in the area, great stuff. We're also hosting the first round of the state sim competition. So if you have either a critical care or an ALS team you want to get into this, come out. We'll do a scenario or two. If you do well with that, you bypass the first round at the state conference. And remember, at the state conference, you get a couple of things. You get a trophy. You get free registration to the next year and a dinner, and then you also get bragging rights. So come out and do that with us, okay? Cadaver Lab. Next Cadaver Lab will be the 24th of September. If I recall that right, that should be a Thursday. It'll be just that afternoon, but that'll be posted on Facebook, and it's free to anybody. Chest tubes, chest decompression, IO. There will probably not be enough to do surgical airways, but we can bring the pig trachs and do that as well, and talk human anatomy as well. There's an EMS conference coming up in Mississippi in Biloxi in October. Should be good for everybody. Then our state conference is also in November as well. I also wanted to give a plug to the Fire College. Their critical care curriculum course starts in October. You can still register online. And this would be didactics and a test prep. The other cool thing with that is that the fellows, Dr. Miller and Dr. Saeed, will be running skill labs throughout the year. So we'll be showing up, doing RSI, critical thinking, reviewing labs, hands-on training. We'll do some cadaver labs with them. And then we've arranged that if you're a student at the Fire College in the critical care program, you can actually do clinicals now at UAB as a student, even if you're a medic, right? And you'll be able to gain access to the ICUs and the ER and do some hands-on. So it's a pretty cool process we got going. And the last thing I would ask is that when you do your evaluation online today, please put in the comments if there's a way we can improve the in-person attendance. I think that's super important to have more hands-on training. If there's something that we as EMS Challenge can do to get more folks to show up at places, please let us know. We can do that. All right? Sweet. Dr. G, it's all you.
Who here does not know what FAFO stands for? Okay, good deal. I don't have to explain. But it's fool around or find out, or fit around or find out. Okay?
Yeah. I'm. That's exactly what it means to everyone online. So that is our clarification. It is what you said is fiddle around and find out, correct?
Yeah.
Fiddle around. Yes. That's a deep Southern term. Right. Thank you.
All right. Unfortunately, I do not have any disclosures. Nobody's paying me to do this lecture. Our objectives: reduce the amount of FAFO. Avoid becoming the patient, and how to recognize and treat anaphylaxis. All right. I have a scale for Alabama patients for FAFO scales: low, medium, high, and maximum. All right. What do you think the first one this ranks in FAFO scale? Sorry. This one, the snake. Yeah. How about this one? Oh, you can't see my pointer. Okay. Does this work? Oh, yeah. Oh. Can you see though? I don't... Never mind. The middle one. Yeah. How about the little ants? Okay. All right. Now some myth busters. Have you heard that you can pee on jellyfish stings? Yeah. Okay. Cut and suck the snake bites. Yeah. Okay. Apply tourniquet above the snake bite. Yeah. Pour alcohol in it. Yeah. Shock it with a car battery. Oh, okay. That was first for me too when I was making this presentation, but apparently it's a thing.
Somebody said they do that in Coleman, is where they do that with the car battery. So if anybody's from Coleman, can you clarify? No, okay.
All right, but all of these are a big no. Okay, so low FAFO scale, mosquito and ticks, they are very annoying, but hopefully you will not get a 911 call for mosquito bites and tick bites. They can spread a lot of diseases, but not an emergency. It can become an emergency later, but not at the moment. All right, I have a cute little video. So this is some kind of lizard, and this guy is feeding a banana to it, and it's asking for its name. And let me show you. And it's looking for, and it says venomous in there, and he's reading it as venomous. So he's calling this guy's name, this lizard's name, as venomous, and calling it so cute. And that's the funny part. So I was gonna say, don't be like this guy. Do not ignore the red flags. Okay. All right. Now, medium FAFOs, brown recluse spider, black widow spider, and jellyfish. All right. This is the brown recluse spider. It looks brown and comes from the name, but is one of the very cute spider. They do not want to harm you. I know it's venomous, and if it stings you, it can cause some problems, but they do not want to come at you. They are rarely aggressive, and bite from these spiders are very uncommon. You can find it in your shoes that have not worn in like months or years. But even if they bite you, most bites are very minor. Rarely their venom, when they inject venom on you, it can cause the venom can destroy wherever it bit. So it's a tissue destroying venom. And even rarer than that, the venom, which is the spindomylinase D, it will cause hemolysis, low platelets, blood clots, and death. Very, very rare. Only 2 reported deaths. I was trying to find how many people have died from brown recluse spider like bites. I could only find 2, and the last one was like 2019. So how do you treat them? Scene safety first. Make sure you don't get bit. ABC, and you can wash the wound with soap and water and apply cool compress for pain and swelling, and ibuprofen or Tylenol for pain control. If the patient is asymptomatic, they do not want to go to the ED, that's fine. They do not need to come to the ED. But make sure you tell the patient that in very, very rare occasions, the venom, it can be deadly. So if they don't feel good, call 911 again, or they can follow up with their primary care provider. Okay. The next one is a black widow. Obviously, the name comes because it's black and there has a red hourglass shape in its body. But unlike brown recluse, you will probably not know that you got bit by this. The skin usually looks unimpressive, but within 130 to 120 minutes, you'll have severe muscle pain, cramping, and a lot of autonomic symptoms. And they will often describe it as worst muscle cramps of their life. It will mostly be on their abdominal muscles, so they will feel it in their belly more. Okay. The venom is alpha-latrotoxin. It's a calcium channel opener, which is why everything cramps. Treatment again, scene safety first, ABC. I can give them fentanyl for pain control, and in the ED, we'll give them benzos for muscle spasms. And there is anti-venom for the black widow spider, but there is no anti-venom for brown recluse spiders. Okay. Black widow, everything contracts. Brown recluse, some dermonecrosis.
Hey, I'm gonna stop you just once. I'm gonna throw in something. The biggest, most common spider bite we see in Alabama is what? Anybody know? Not the spider. Yeah. Yeah. So we call it in the ER the MRSA spider. Anybody know what MRSA is? Yeah, so it's a staph infection. So you get a lot of people that say they were bit by a spider and they got this big abscess or boil. In reality, it's probably a little folliculitis, an infection around an ingrown hair, or somewhere where they scratch themselves, have an infection, and they think it's a spider. So not a lot of bad spider bites out there. And I'm like you, I think there's been a couple of deaths from black widow. I think the antivenom for the black widow was probably worse than the venom. Yeah. But if you're dying, that's a different situation. Yeah. A lot of it could be kind of anaphylaxis as well, or an allergen to these things.
Yeah.
The brown recluse, You won't see that wound. The way we diagnose that in the ER is you come in, you say you got a spider bite. I go, sure, whatever. I look at it. If it looks infected, we do antibiotics. They come back 10 days later and it still looks horrible. So at that point, we start culturing, switching to antibiotics. They come back 10 days later and it's still not better. Then I go, maybe this was a brown recluse. And they go to the surgical care center or wound management and get that. So not a lot of fatalities to the brown recluse. I think if somebody has a spider bite or a wound from some kind of bite and they have systemic concerns, that's when you should get scared. The other thing is, I like to mention the fact you mentioned scene safety. But if you got to think scene safety with spiders, it's just time to leave anyway, because that sounds very, very creepy.
Yeah.
So, all right, sorry, I'll leave you alone.
Okay. The other one is jellyfish. There are a lot of jellyfish that you just get stung and it's just a little rash and you move on. There is one, Portuguese man o' war, which is technically not a jellyfish, but it does look like one, and the bite can be very painful. This is what it looks like. It's very pretty, and even if it dies, and you'll see them like washed up in the store or the beaches, and even after it dies, the stinging cell remains fully active and is capable of injecting venom. So people should not be touching or kind of trying to take a picture around it. But its venom is mostly used to paralyze fish. The sting is very, very painful. It can cause systemic symptoms like fever, really, really bad muscle cramps. So treatment, again, scene safety, AVCs. You can try to pluck the visible tentacles with fine tweezers. Make sure you put some gloves on. And you can soak the skin in hot water. It's not going to remove the tentacles, but it will help with the pain. What not to do is to pee on the jellyfish sting. Or use your bottled water or any kind of like other fresh water to clean the jellyfish wound. You can use salt water or like seawater to rinse it, but do not try to rub it with anything. No scraping, no pressure bandages, no alcohol, no ammonias. And if the patient has severe symptoms, you can obviously transfer to the ED. Okay. High FAFOs are our snakes, copperhead, rattlesnake, and cottonmouth. These are the snakes that you'll find in Alabama. That's not one of them. I just thought the picture was really pretty. But I want to start by saying that these snakes, they are very important to the ecological systems. They help they eat all the rodents, little small mammals, so they are very, very important. I know they look scary, they sound scary, but they do not want to bite you. They will only bite you if they think if you're trying to like mess with them. Okay. Alabama has around 50 different species of snakes. And out of them, only 6 species are venomous. And out of the 6, 3 of them are rattlesnakes. Okay. Has anybody ever seen these signs? Do you think there is any problem or a problem with this sign? Yes, exactly. Venom versus poison. Venom, if it bites you, you get sick. Then that's venomous. If you bite it and you get sick, that's poisonous. The first one is copperhead. It's a very, very pretty snake. It's a pit viper, and it has a very distinctive hourglass shape in its body. It looks like Hershey's Kisses from the side. Vertical pupil, and the baby copperheads have this little tail, yellow colored tail that can be used as a lure. Right there, it's a baby copperhead. And so good news that if you get bit, it won't usually kill your patient, but it will definitely ruin their week. Okay. The venom is hemotoxic and affects blood and tissues. There's going to be a lot of like tissue damage, swelling, bruising, and blistering. It's very rarely fatal, but the patient does need to go to the ER. Treatment, again, scene safety, remove the patient from the scene. AVC, if it bites you in the face or neck, think about the airway. you do expect significant swelling and bruising from the bite. So think about airway. Document the bite time, mark swelling, remove any rings or watches or tight clothing because it's going to swell up. Another thing that you can do is keep, if it's a hand or leg, you can keep it at the at or near the level of the heart during transport and initial evaluation. And the reasoning, it's pretty theoretical, but is apparently if you put it too low, gravity increases the hydrostatic pressure, and it can worsen the edema, pain, and swelling. If you put it too high, the elevation increases the lymphatic and venous drainage, potentially increasing the systemic absorption of the venom. This is all theoretical, but there's not a lot of things that we can do. And obviously mark the edge of the swelling, make sure you make sure they have pulse, make sure their neuro exam is intact. Again, elevate the limb at the heart level. You can give them pain medicine, opiates for pain. At the ED, we'll give them tetanus, and we'll consult our toxicologist and observe for progression. Do not cut the wound, suck out the venom, do not apply ice. So the reasoning behind this is ice is treating the inflammation by constricting the blood vessel. Venom is already causing a lot of tissue destruction, including the blood vessel. So restricting the blood flow to the already injured area is just going to make the damage worse. So do not use ice. Do not use a tourniquet because the venom is spread through your lymphatic system. It does not go through your blood vessel. So even if you put a tourniquet and kind of cause ischemic limb, the venom is still going to spread. So do not use a tourniquet. Do not shock your body with a car battery. Apparently that's the thing. Okay. In the ED, if the swelling is rapidly progressing or causing a major joint, if you see systemic toxicity or coagulopathy, we'll usually consult toxicologist and think about giving them antivenom. We have two different kinds of antivenom for this, Crofab and Anavep. Crofab is made from sheep and Anavep are made from horses. But again, like Dr. Ferguson said, antivenom can cause a lot of anaphylaxis. So we always look at the risk versus benefit before we give antivenoms. Okay, rattlesnakes. These are another very pretty species. There are three types of rattlesnake that you'll find in Alabama area. Timber rattlesnake is the one with the brown stripe on the top. Pygmy rattlesnake is the colorful one, and eastern diamondback rattlesnake is the one on the side. One of the things is if it doesn't rattle, that does not mean it's not a rattlesnake, because the baby rattlesnakes they only have the small little button, so you may not hear the rattle. If it's an adult, they can lose their rattle over time. So, and eastern diamondback rattlesnake can reach up to 5 to 8 feet in height or length. Good news that it usually gives you a warning. I don't know if you guys have watched like YouTube videos about people trying to find rattlesnakes, copperhead, or cottonmouth, but usually they give you a very significant warning, or like they don't bite you all of a sudden. They will rattle their tail for a long time before they actually bite you. Obviously, they will upgrade your care plan if you keep ignoring the warning. 20 to 25% of the time, rattlesnake will they do not inject venom, which is called dry bite. And you'll find them mostly in fallen logs, like bush piles, rocky area. They usually come out in warmer months to sunbathe. And for the venom, it's a mix of hemotoxin, cytotoxin, myotoxin, and a lot of proteolytic enzymes. So it will cause very severe pain, rapid swelling, hypotension, nausea, vomiting, shock, DIC, which is bleeding and clotting at the same time, and even compartment syndromes. So treatment, again, scene safety, ABCs, document bite time, mark the swelling. Expected to get like expected to swell up pretty significantly, so remove any rings or tight clothing. Immobilize the extremity, keep it at the level of the heart. Again, you can give them opiates for pain medicine, and we'll consult our toxicologist and when they come to the ED, see your labs, and think about antivenoms. Okay, cottonmouth. It's another very pretty looking snake. Whenever it feels threatened, it will coil up and open its mouth, and it looks like white cotton. That's where the name comes from. Good news, usually lets you know it's unhappy by opening its mouth. And bad news, it lives where your patient decided to go fishing barefoot. So it's a semi-aquatic pit viper. That means it will live near like slow rivers, any kind of creeks. It is venomous, but like I said, it will give you a warning. Okay, venoms. Its venom is hemotoxic, cytotoxic. Systemic toxicity is less common, but it's still an emergency because it causes very rapid pain, very rapid swelling and bruising and tissue damage. Again, treatment, scene safety, ABCs, cardiac monitor, document bite time, mark the swelling. If it bit your face or neck, think about the airway. Do not apply tourniquet, ice packs, or heat packs. Do not attempt to catch the snake, and treat the pain. All right, special mention of coral snake because they're very rare. There are many different type of coral snakes. The only venomous one that you can find in Alabama area is eastern coral. It's the one on the top. One way you can recognize it is if the red stripe are close to the yellow stripe, then you know it's venomous. They're more common is our scarlet king snakes, and there are red and black. And also you can also see the snout of the eastern coral snake that has black snout. That's also can tell you that it's venomous. But the color pattern doesn't really apply for Mexican coral snakes, but you'll probably not find Mexican coral snake around here. But if you're not a herpetologist, you'll probably not try to identify the snake because eastern coral snake, it has neurotoxin and it will cause significant pain, paresthesia, respiratory failures, and weakness. So better to just bring them to the ED. Okay. Any questions about snakes? Okay. All right. Case, 35-year-old male, bee sting, says I feel weird, blood pressure 84/52, diffuse hive, breathing very fast. What do you do? What do you think is happening and what do you do? Excellent. Okay, now this is maximum FAFO, which is anaphylaxis. You wouldn't think bees are very high in FAFO scale, but it's not everybody has allergic reaction to these, but bees, wasps, and gnats, they can be pretty scary. And one of the other thing is when bees bite you, they will lose their stinger and they die. Wasps, they can bite you as many times as they can. If the patient has been bit like multiple times all over their body, even if they don't have anaphylaxis, they can have muscle breakdown, which is rhabdomyolysis, and go into kidney failure. So even if they don't have any signs of anaphylaxis, you can just go ahead and bring them to the ED. Okay, what is happening in anaphylaxis? Basically, body sees a very non-threatening, a bee bite, wasp, or a gnat, and it is just going crazy. It's deploying everything that it had at its disposal to try to get rid of the nuts. Definition of anaphylaxis: acute onset, has skin plus mucosal involvement and respiratory compromise, or hypertension or any kind of end organ dysfunction. Or we can kind of define by acute involvement of greater than 2 system after a likely allergen exposure. But if you are ever confused whether this is just like a mild allergic reaction or anaphylaxis, just go ahead and treat it as anaphylaxis. Okay. What all do we look for? Hives, flushing, angioedema, lip swelling, kind of periorbital swelling, wheezing, vomiting. I know. Like I said, if you ever have question, if you're ever confused about this, if this is just mild allergic reaction or anaphylaxis, just go ahead and give them epi. Patient says, I think I'm allergic, my lips feel funny, my tongue feels big, I can't breathe, epi. Worst case, you give epi and they didn't need it. Best case, you give epi and they're alive to complain about it. You will never hear anybody say that EMS give epi too early. Epi does have side effects, but death has a pretty significant one. Dosing. Adult 0.3 or 0.5 milligrams IM. You can give them every 5 to 15 minutes in your lateral thigh. You can also, if you have that epi injector, you can just inject through their pants or whatever they have wearing. Peds, we go by 0.01 mg per kg IM. For a patient who are less than 20, you can give them 0.1 if it's 10 kilo, 0.2 if it's 20 kilo. But over 20, you can just go ahead and give the regular adult dose. All right. You gave epi and you're transferring the patient to the ED. What all do you look for? Okay. Well, make sure you look at the blood pressure. If they're still hypertensive, if they're still having respiratory distress, you can give them another dose of epi. And after 2 doses, if the patient is not looking any better, you can consider epi drip. For adult, the starting dose for epi drip is 0.05 to 0.1 mics per kg per minute, and you can titrate it every few minutes to work for breathing, oxygenation, and blood pressure. One way you can do it is you can mix your 1 milligram of epi with 100 ml of normal saline, and you'll get 10 mics per ml. For a 70 kilo patient, you can start with 3 to 7. It's a little hard to titrate in 100 ml, so you can always mix it with 1,000 cc's of your normal saline, and it will give you 1 mics per ml instead of 10 mics per ml. Pediatric, same dosing, but obviously go by weight. If it's a 20 kilo child, you can do 2 mics per minute. Or if you go by hour, 120 mics per hour. Okay. Again, secure the airway. This is what the normal airway looks like, and this is what a swollen throat looks like. In their larynx, that's the normal larynx on the side, and this is a swollen larynx over here. Obviously, you won't be able to see this unless you look for it, unless you're trying to intubate. But don't wait until you can't intubate. If they are having really bad hoarse voice, stridor, tongue swelling, drooling, and you've given like epi, you've given them epi drip, think about intubating. You can give them other medicine like Benadryl, steroids, and famotidine if you have, but the only medication that is helpful in the acute setting is epi. Okay. And this is algorithm. Give them IM epi, hypertensive, think about infusion. You can also give them fluids. All right. If you give them IM epi and they start feeling better, the patient needs to come into the ED even if the symptoms improve, because once the epi and once their symptoms can recur an hours later. So that's why we observe them in the ED for around 6 hours. And they can have biphasic reaction. You have anaphylaxis, give them epi, feel better, and their symptoms can come back a couple of hours later. Okay. Special mention is for fire ants. They can bite you. Their stings are pretty painful, but one thing to know about this is that their bites can cause anaphylaxis as well. And for scorpions, I was looking through stuff. Apparently, Alabama doesn't have any venomous scorpions unless somebody's collecting them. There are scorpions like Arizona bark scorpion that have very neurotoxic venom, but that's not, you won't find that in Alabama. Okay. So final, don't become the patient. Think about scene safety. Anaphylaxis, just epi. And don't bring the snakes. I don't know if patient try to do that here, but it's a big thing in Nepal. Yeah, that must be fun. But any question?
Yeah.
No.
Yeah, I've seen them bring snakes in bags, in a lunchbox, in a bucket, so all kind of weird things. So I like that. So the epi guidelines, the new dosing for epi, which I'm sure y'all already heard, for anaphylaxis, used to be 0.15 for kids less than 30 kilo. If you're 30 kilos or bigger, you get 0.3, right? Now we're doing 0.3 for folks less than 30 kilos and 0.5 for everybody else. So we kind of like doubled the IM dose. Don't be afraid of using epi-IM if you're looking at somebody and they have two organ systems involved in an allergic reaction. So rash and wheeze, rash and vomit, hypotensive, facial swelling, stridor. IM epi. It's quick, it's easy, it's early. Yes, as you're doing that, you're still going to be starting, IV access, probably give them some fluids, may throw an albuterol or racemic epinephrine treatment in, but epi is the drug for systemic complaints. So IM is great. And like you said, every 5 to 15 minutes, there's no risk. There's limited risk in somebody with anaphylaxis. If they're like 98 years old, then there's a problem, right? But otherwise, you're probably fine. And I would say for rebound, if you've given 2 or 3 IM epis, it's probably time to think about doing an epi infusion. My suggestion on that is either have a close relationship with your medical director so you already know what you're going to do, and or it's a quick phone call to med control. Hey, I got this 48-year-old guy. He got stung 1,000 times by yellow jackets. I've given him 3 epis IM, Benadryl, Salumedrol. I'm coming to you, but I'm going to start an epi infusion and titrate it to effect. Thanks. See you in a few minutes. Right? So tell them what you want, what you really, really want. Right? So that way you can get what you need, what you really, really need. So epi is your friend in anaphylaxis. Don't be afraid of it. You mentioned something about don't peeing on jellyfish stings, right? So I would say also don't pee on the jellyfish. So you cannot prophylactically treat the jellyfish before it gets you, because that will lead to stings in places you don't want to get stung. And it's kind of funny later, but not at the time. What else do I have? The other good thing in Alabama is that if you call poison control, we have a toxicologist who also runs a snake bite clinic at UAB, one of the only snake bite clinics in the nation. So a great resource. So if you're stuck up in the Sipsey wilderness and you got to decide when we get this victim out of the woods with the snake bite, where do we go? What do we do? Who has antivenom? Who does not? That is a great resource, and TCC can connect you to those people. But UAB does have a snake bite clinic. Our ER will accept patients from other places with snake bites for the most part, within reason, to take care of those as well. The old school days of these snake bite victims that have these big swollen extremities getting fasciotomies is over, because that just causes a lot of long-term issues. So a lot of good things we can do. Use your resources. Cool. Questions in the room? Questions online, Chief or other Chief?
Hey, Doc. So just one thing. Would you mind talking a little bit about why we give the epinephrine IM rather than, say, 1 to 10,000 IV for anaphylaxis?
So it's a different dosing for IV epi, right? So I have to look it up, but it's a different dosing. It's much easier to just have like an IM epi ready and stick it in there, and it's 0.3 or 0.5, and it's much easier. So that's why we always go with epi. If it
So the misunderstanding can come is when we already have an IV and then recognize anaphylaxis. A lot of times EMS personnel will think IV is more dependable, more measurable. I've already got the IV. I'll give them cardiac epi for anaphylaxis. So, yeah, so the reason is the drug distribution. And Doc, if you want to.
Yeah, my reason is safety, because you're going to make a mistake if you do that. So historically in Alabama, you could call med control and get orders to give 1 to 10,000 IV for anaphylaxis. My suggestion is do not do that. You're going to be given IM epi. if you're going into your second vial of IM epi, that's when you got to start thinking about this rebound and the need for epi infusion. Epi 1 to 100,000, maybe you can use that as a shock protocol as well. But I can tell you that the risk given too much cardiac epi IV is real. You can put people into VTAC, VFib. And plus the duration, the way it's absorbed, IM works better. And we're doing IM, not sub-Q, like some folks, like we used to do years ago. You want to deepen that muscle, right? So it's the deltoid, it's the thigh. One of those two is where you're going to go with that. And it should not take but a few minutes. In our state, the EMT can give the EpiPen, right? So if there's an EpiPen already, you can do that. In reality, this might get me in trouble, but if an agency bought EpiPens, you could use that as well as a basic EMT. I think that in the near future, we should make it where you could do it IM by drawing it up because it's cheaper, but the EMT can use EpiPens as well, just FYI. But again, that's a discussion with your medical director to make sure you're all on the same page.
Yeah, it's not wrong, but the dosing is different, and you have to be really careful.
Right. So I've had patients that have ingested something like peanuts or a peanut butter cookie, and they've got a couple of doses of IM epi, and it kind of wears off, and they're still having a reaction to this. Those folks will go to the ICU and a low-dose epi infusion sometimes. Or I've seen the guy that's got 48 million, yellow jacket stings. Those things are of the devil, right? In the same process as well. So limited risk to epi. The biggest risk is if you give it IV and you give the 1 to 1,000 IV, you can literally put somebody from a normal sinus rhythm into VTAC, VFib. And although that lets you practice skills, it's not good to do that because that could potentially kill your patient.
Is there a distinction in EPIs that comes to like 1 to 1,000 versus 10,000 with the EMS? Or?
Yeah, there's a distinction. So 1 to 1,000 is usually a vial or an ampu. The 1 to 10,000 is in the Brista jet, and they have to make their own 1 to 100,000, which
and oftentimes we have to make the 1 to 10,000.
Right, as well, correct, right. And it's different for us. So like practicing in the ER, most of the time, most hospitals are not going to let us make a epi push or push dose epi. That is a pharmacy required thing. We cannot make drugs. They're afraid of the mistakes, the errors, and those errors are real. So the fact that y'all can do it is a great bonus for you guys because there's no way to carry every concentration, every administration of med out there. But you can't make that mistake. And I can tell you, I've seen it several times where somebody's given the wrong dose of epi instead of IM going IV. And I've seen it with other drugs as well, such as ketamine. You're drawing up ketamine to give somebody ketamine IM for agitation. And lo and behold, somebody gets the IV. They yell out, "I got an IV." So you hand them the IM dose of ketamine, and that's an intubation dose, right? So you don't want to make those mistakes. We can't save everyone. I get that. We all have their bad outcomes, but you can't kill anybody. That would get you in trouble, right? Other questions, Chief, or other chiefs that are out there? All kind of chiefs.
You really didn't mention much about diphenhydramine or using albuterol for allergic reaction. How big of a role do you think these secondary drugs play in a serious reaction to a wasp sting, for example?
Yeah, and Benadryl, it's antihistaminic medicine, right? It has not shown to have any mortality benefit in all the research that we've done with anaphylaxis. So only epi. You can give them Benadryl, but give them epi first, and then you can give them Benadryl or anything else that you have. It has been shown no mortality benefit.
Yeah, so no mortality benefit, I agree. Epi is the first drug. After you give the epi, you're going to be watching them for a couple of minutes. As you're watching them, you're doing your other things. Secondary exam, passive O2. If they're wheezy, sure, give them a NEB treatment. They'll feel better with that. IV access fluids, because they're probably going to have a soft blood pressure and tachycardia. That'll make them feel better. All right, steroids for down the road. So if you start getting that rebound, you're already hitting that off at the pass before you start. And then Benadryl, no mortality improvement. But I can tell you, when I've been stung by yellow jackets, I'm popping steroids and Benadryl and epi and other things, legal things. Make sure to clarify that. So Benadryl is reasonable, right? So, and the dose for Benadryl is 1 mg per kilo, and you cap out at 50 milligrams. All right.
Yeah.
Solu-Medrol for the adults, 125. For the kids, you got to look it up just like I do. All right. Cool. And I don't think anybody carries Pepcid in the pre-hospital world. But we do that. People say, but Pepcid, Zantac, these H2 blockers, why do you do that? And that's because these drugs are not exact. They do have some H1 as well as H2 blockage in there. So it's a great drug. Limited risk, great benefit. But to stress again, epi is the drug of choice in anaphylaxis. Okay? People die from anaphylaxis. They don't die from allergic reactions. They think they're going to die from being stung by a jellyfish, though. I can tell you that.
So one thing that always comes up in the snake bite lectures is the antivenom. EMS folks have questions about the antivenom, and it's always a discussion about how much does it cost? Does people's insurance cover it? How often do you actually give it? How much do you have to give them if they have a serious envenomation? So what's the deal with that? Is it super expensive? Is it?
Not sure
Is it
about
gonna
the
put
price.
you in debt for the rest of your life if you get bitten by a copperhead?
Yeah, so there's a cost to everything in healthcare, but relative, it's not that bad. It's cheaper than a cyano kit or about the same price. So, I mean, it's the price of PCC. I don't know the exact cost of it. The key to it is knowing how to use it. And there's no way that your guys are going to know that. There's no way that I'm going to keep up with that completely. But what I do have is I have my phone a friend. I recognize, oh, snake bite, ooh, swollen, ugh. I'm going to start IV, start resuscitation. I'm going to call Poison Control Center and get that toxicologist on the line that has a snake bite clinic. There's somebody open 24/7 to talk to you about that. And they're going to say, oh, yeah, this person does not need antivenom. They can go to hospital X. Great, roll tide. Or they can say, oh, no, they need antivenom right now. Go to hospital Y. So that's the point there, is get that resource early on.
Yeah. And so all the snakes that you talked about being in Alabama and being venomous, with the exception of the coral snake, they're all pit vipers with very similar venom, correct?
Yeah.
And so the only exception would be if somebody had an exotic snake captive, right?
Yeah.
That bit them, that wasn't a pit viper, then the antivenom that's currently stocked at, say, UAB wouldn't work. Is that correct? In
Yeah.
other words, if you had a gaboon viper or a cobra bite,
Yeah, so
Prolab would be of little use. Is
yeah,
that correct?
again, that's why I would be using those resources. I'm going to do the primary exam, recognize the need for help, stabilize them, O2, IV access fluids. If they're anaphylaxis, I am epi, and I'm calling TCC to get that toxicologist that knows these things. All right. And if you can identify that snake, they can point you in the right direction of who has that antivenom or what's going on with that. Again, use your resources, because I'm going to be phoning a friend in a heartbeat with those things.
I know my fear, probably other people too, is always have these, some guy living in a dilapidated trailer out in the woods in our territory, and his trailer's worth $6,000, but he has $50,000 worth of exotic snakes and homemade cages, and then the thing catches on fire and you go in there and there's snakes everywhere. That stings a little bit right there. Yeah. Just remember, Doc, we're both from Mississippi, so we can't get too rambunctious. Hey, thank you for a great lecture on envenomation.
Absolutely.
Sir? Yeah.
No, that's going to be a hospital thing. Yeah. And the biggest issue, I think, is not just the cost, because flight crews carry drugs that are just as expensive or almost as expensive. The problem is the mixing. If you don't gently agitate it, mix it the correct way, it messes it up, and you've wasted that stuff. So that's the issue with the storage and the administration of it. So, yeah, so there is a potential. So in the past, there have been air medical resources that have been utilized, taking medication on scene for someone. But the problem then comes in, they probably need to take someone who's administered that medicine before to help administer it, because if you screw it up, it's like the cyano kit, right? You can use it, but if you mix it up wrong, it doesn't work. Same thing with this. So it's that resource utilization of that. So yeah, I think it varies depending on the patient, how much envenomation you had, and their underlying health problems. So there's probably a scientific, a medical answer that you may have, but my answer is going to be, it depends. Yes, sir. Yeah. I say if you get bit, you start moving out.
Yeah. Yeah. It will start to swell up. If it's obviously if it's a dry bite, then it will have like probably mild swelling and it will go away. But if it's a pretty significant envenomation, then it will swell up within a couple of hours you'll see like massive. Yeah.
They basically mark yours again. They measure it circumference-wise every like 2 to 3 hours. If it's getting bigger with a significant amount of time, that's when they decide like, okay, we need to give you antivenom. Now, also, the biggest concern immediate will be anaphylaxis, just like anything. So, like you said, if you get bit, just you need to start moving. Forget the hunt, because you're the prey.
Yeah.
You're the prey.
You're the prey now. That's right.
Yeah,
It's like that movie.
You know, the biggest lesson is in the data about snake bites, about who gets bitten in the United States. And it's predominantly males, right, between the age of 10 and about 40. They're predominantly bitten on the hand. The few females that get bitten are bitten on the lower extremity. So what does that tell you? But it tells you that testosterone is actually probably the most dangerous venom, right? And if you don't pick up the snakes and mess with them, they probably won't bite you.
Yeah, but that's also related to Budweiser, I do
It's
believe.
also related to Budweiser consumption.
That's right. So, all right.
I had an
Thank you.
18-year-old supposedly bit by a copperhead. And he had like 2 little bite marks, and it was marked, and we watched him for 6 hours in the ED, and he didn't have any like swelling. So I think it was just a dry bite, or something else, some other snake that was not venomous. So he was fine. A lot of times they end up being fine, but a couple of times, very rarely with that venom, it can cause very significant swelling very rapidly.
All right, everybody. Thanks, Doc.
Yeah.
Great lecture. We're going to take a short break, and we're going to come back with Dr. Saeed.
All right, y'all. I hope y'all enjoyed Dr. Ghimire's lecture. It was really good about poison bites that we see a lot, and we're going to see a lot more because summer's coming to an end. People are gardening. People are mowing lawns and stuff. So snakes, they always bite when you least expect them, I guess. My name is Ahmed. I'm one of the EMS fellows. I will be doing the Pelvic and Extremity Trauma lecture today. This is something we see quite a bit in the field. Some of it is non-emergent, but the things where we make a difference, we really make a difference in the mortality rate. All right. Disclosures-wise, just like Dr. Ghimire, we're not getting paid. We have a sponsorship by the Alabama Fire College, and we ask our UAB Emergency Department physicians and the residency program to come give lectures so that you guys are getting physician lectures. All right. The biggest objectives for today, we're going to review some pelvic anatomy, lower and upper extremity anatomy. We're going to do some image review, which not as relevant for you guys because y'all don't have x-rays in the field, but it's good to know what we're looking at, what's happening underneath. How to mitigate any kind of pelvic injury, how to do some good hemorrhage control, management of fracture and dislocations in the field, and then review of the Alabama guidelines that we have for you guys for these injuries. All right. Now, why does this matter? Extremity and pelvic trauma usually is one of the major causes of death, because what kind of shock do you have in the field till proven otherwise? Hemorrhagic, right? Your pelvis can hold a lot of blood, and that's not something you're seeing pouring out. So this is one of those injuries that you don't think about till it's like the patient is crumping really bad. So this is something to always keep in the back of your head when you see some of these pelvis injuries. We are the first line of intervention in this, right? What we do is really going to make a difference. Like with a lot of the cardiac arrest, respiratory arrest, emergent traumas, what we do starts the clock, and what kind of interventions that we have in the field really affects the mortality that the patient will have, right? So don't take your job seriously, like I know you do, but don't get complacent. Just because you've seen a lot of wrecks and nothing's happened, it only takes one to go down south, right? So always approach every single scene with the same vigor that you had when you were a rookie, all right? And then if you carry blood, this is the time when we gotta start thinking about giving blood for these people. Nope. Two different types of pelvic trauma that we get. We get blunt trauma. We see a lot of these motor vehicle accidents, crush injuries at like these work sites where cranes might fall. Right now, there's a lot of roofers and painters out there, so you're gonna get a lot of fall injuries for blunt trauma. Unfortunately, in our area, we get a lot of penetrating trauma. So this is mostly GSWs to the buttocks, to the groin. You will get impalement, stabs, And then hopefully you guys are not seeing this last part as much. This is more in the military side, unless you work in the quarry or you're one of those meth labs somewhere in a causing blast fragments, you know. So that's something to keep an eye on. All right. Biggest takeaway that I want you to get out of pelvic trauma is any kind of suspicious mechanism injury, you get hypertension, bradycardic, and you do not see an obvious sign of why this patient might be doing this, you suspect a pelvic injury. All right. So it won't take much to stabilize the pelvic. Even if they don't have a pelvic injury, at least you've ruled out something that potentially could be happening. Let's go through the anatomy of the pelvis, right? There's your three bones that make up your pelvis. You have your ilium, you have your ischium, and then you have your pubis, right? Between that, you have the socket. I can do that. Don't work that well. You have your socket right there, the acetabulum. That's where the head of the femur is going to sit, okay? The pubis is connected with the pubic symphysis right there. It's a little elastic-like band that holds it together. Then in the back, you have your sacrum and your coccyx. These are your tailbones that you will hear. And then as you notice, the pelvic inlet, the circle area between the male and female pelvis is a little different. Then the male pelvis is a little narrower, and then the female pelvis is a lot rounder. Now, mostly the roundness is to help with childbirth. That's why it's a little wider in females, okay? But the three biggest bones that create our pelvis is the ilium, ischium, and pubis, and these are the ones that cause most of the problems that we get. Pathophysiology of the pelvic trauma. So in your stomach, there's the peritoneal sac. That's what holds most of your organs. Your organs aren't just like flying around in your stomach, right? There's a peritoneal sac, and then you have a retroperitoneal area. So that means behind the sac. Behind the sac is where majority of your vessels lie. What kind of vessels do we think are back there? Think about your anatomy. Descending aorta. What else? Renal arteries. So aorta is giving blood out. What's bringing blood back? Inferior vena cava, right? So you got your big descending aorta right there, going all the way down to your iliac arteries. You have your inferior vena cava going to your iliac veins. A lot of vasculature and nervous system, right? You got your nerves coming out your spinal cord, going all the way down, right? That's where you get sciatica, a lot of the cardiac equina syndrome. So these are things that you got to think about in pelvic trauma, that these are the structures that are going to get injured. Now, if you have a major bleed, it's going to be behind the sac. So you could get a retroperitoneal space that could hold up to 2 to 4 liters of blood, right? That's a lot of blood that's sitting there, but you're not seeing it because it's just collecting behind the sac. Even if it was in the sac, now that we're starting to get pre-hospital ultrasound, you can kind of see that in ultrasound, but you can't see retroperitoneal bleed on an ultrasound. So just because you didn't see any fluid in the abdomen doesn't mean that they're still not bleeding. All right. So always keep the suspicion of the retroperitoneal high in your differential. Now you will get pelvic ring fractures. So these are your open books. These are your vertical shear fractures. These are your lateral fractures. These are the ones that are going to cause vessel damage. Open book fractures have the highest mortality. How many of y'all ride motorbikes? All right, yeah, y'all in the medicine world, y'all know what y'all see. So open book fractures happen a lot with motorbike accidents. All right, like I said, hidden bleeding, hard to detect, but the only true safe for this is coming to the ER, getting our interventional radiologist there, where they put the patient under imaging, and then they go and embolize the bleed. There's no other cure for that. We can't do anything in the ER. You guys can't do nothing in the field outside of mitigate and buy us time, right? That's what all we're doing is buying us time till they get the definitive care. So like I said, the amount of vessels that you have, look at all the vessel and vasculature and nerves around your pelvis. You don't think about that, but these are really big vessels. You got your descending aorta, inferior vena cava, your iliac arteries, your veins right there. Then you have your nerves coming out from your spine back there. So this is a very vascularized region. So you have to have your suspicion high. So the different types of pelvic fracture we have, right? We have your lateral compression fracture. So this is mostly when the patient gets T-boned in the car. The angle that it comes in causes a little sideways force. You get your lateral compression fracture. Then you have the windswept pelvis. So this is where basically, mostly in rollover injuries, this is going to happen is where you get T-boned, but at the same time you get force from the front, so you're basically twisting a little bit, and as you're rolling over, you're twisting. So this is going to cause the vertical shear anterior posterior fracture and a lateral fracture at the same time. Then you have your vertical shear. So these are your patients that have falls from greater than 10 feet. You got to think about all that pressure that goes up causes a vertical shear fracture happen. And then your anterior posterior compression fractures. This is basically the ones that we should see the most of, most likely. Patients driving fast, runs into something, and then you get all that force coming from the front. It's going to go through your femur. So what else do we suspect? Femur fracture as well, right? And then goes through your pelvis. What do you notice in this picture that's different? Exactly, right? So right here you can see your pubis is widened compared to, say, right here, right? Or right there. Even though they have different types of injuries, but you notice the difference. And this is where all your blood is going to be collecting, right here. So imaging wise, your vertical shear, you have the posterior superior directed force. It has the highest risk of hypovolemic shock because it's higher up. You get your ilium right here that's fractured and your pubic bone right here that's fractured. Okay. On that farther side, on this side, as you can see, so when we're looking at this X-ray, this is the patient's right and this is the patient's left because we're looking at it, right? So like it's like looking at the patient straight up. What do you notice a difference between in this image? The fracture, right? Yeah. So the way I approach looking at imaging is you're going to look at both sides. So you see this side is nice, looking good. You have your nice ovals right there. And then you look on this side, it's not lined up right here, right? Look at that difference. So it's gone up. So it's a vertical shear fracture. And then this is the one that gets missed a lot because you just get focused on the big one. But then you look at your pubis bone right here. You see how this is a nice symmetrical area. But here you see it kind of misses it and it's not aligned. So you have one here and then you have one right there. So these are things you start looking at. And the more you look at, you understand the type of injuries you're getting. Then you got your lateral compression fractures that we talked about. There are 3 types of lateral compression fractures. You have your lateral compression fracture 1, and that's how to grade. The worst type it is, grade 1, 2, 3, the worst injury it is. So in your lateral compression fracture 1, you have your oblique and transverse ramus. As you can see, they have oblique fractures right here. This is an oblique fracture, and then you have your ramus fractures up there. And then in 2, it's basically the same thing, but you also get a posterior dislocation, and it's called the crescent fracture because technically it looks like a moon a little bit. Not as well, but it looks like a moon a little bit. On the 3rd one, you get the same as the grade 2, but also you get fracture on this side, on the anterolateral side, and your ligament is going to tear. And this is the one that's going to cause the windswept pelvis, the rollover one. It's going to have a lot of bleeding internally that you're not going to see. The anterior posterior compression fractures, you have same thing, 3 types of grade 1 to 3. Grade 1, your pubic symphysis is slightly widened, not a lot. Grade 2, you see a decent widening, and you see the anterior sacroiliac joints. So your sacroiliac joints right here are also dislocated and torn. In the 3rd one, you have even worsening widening, and then you get your full torn sacroiliac joints right here, And then this is what worsen, widen, and separated as well. Okay. These ones, the type 3, highest risk of vascular injury. Now, how do we in the field check for pelvic stability? Here, there you go, carefully. Now, the way I do it, and the way we do it in the trauma bay, I'm sure you've seen us quite a times when we're doing our primary survey, is you put your hands on the iliac crest. So find your iliac crest. It's higher than you think. Am I the only one doing it? Y'all don't want to do this? All right, find your iliac crest, and then you put your hands around it, okay, and rock it back and forth, just like that. It's not very sensitive. It's not very specific. But I tell you, one of the biggest signs that you know that you have an unstable pelvis will be as soon as you touch it and rock it, they're going to want to punch you. It's going to be very painful. If it's painful, more than likely it has an injury right there. Okay. And just like I said, out of caution, if you have any kind of concern that it is a pelvic injury, even if you don't get a positive test, do the pelvic trauma treatment that we're going to talk about, right? Put on the binder, err on the side of caution. I don't expect y'all to be looking for perineal bruising. If you're looking for perineal bruising, I don't know what's going on. This is what we'll do in the ER mostly. But if you see it, it's good to let us know. And then, like I said, if you see hematuria or you see blood of the meatus, that's a big sign of vasculature and urethral injury as well. Make sure you notice the leg length discrepancy. That's a big sign as well of a dislocated hip or some kind of fracture. And then if you get, like I said, I'll keep harping on this. If you get shock with no visible bleeding, think about bleeding in the retroperitoneal space into the pelvis and treat it like a hemorrhagic shock till proven otherwise. Pre-hospital treatment for pelvic trauma, initial interventions, always don't let an injury distract you from what you're supposed to be doing, your primary and secondary, right? Your primary is always airway, breathing, circulation, right? Make sure the patient is stable in those 3 phases before we move on. You want to put the patient in supine positioning, and then pelvic binder. Very important, right? This is where we do make a difference. You put the pelvic binder, where do you put it? Exactly, it's on the slide, y'all. Like, the answer's right there. It's at the greater trochanterus. Where are your greater trochanterus? At the head of the femurs, right? Right at the head. And then trauma alert this patient, put them in TCC and get them to the appropriate place. Then you want to get IV access. You want to reassess this patient multiple times. And then in this patient, if it is a hemorrhagic shock or shocky patient, this is where I will consider TXA and consider giving this patient blood if you carry blood, right? These are things that you should be thinking 5 steps ahead of what should be happening, because you've done, you practice so much and you approach each case with the same vigor as you do with anything. Even if you're on your 22nd hour shift, right? Because this is somebody's aunt, uncle, sister, wife, daughter, husband, son, right? What we do is makes a difference. When they see us, it's more of a sigh of relief, like, oh, help is here. So let's treat it with the same type of respect that they're giving us, okay? What is the purpose of the pelvic binder? It's not going to stop the bleeding. It's going to slow it down and cause tamponade, right? Placement of the pelvic binder should not delay transport, okay? Let's not dilly-dally around on the scene. Hey, where's the pelvic binder? Who has the pelvic binder? Oh, well, let's start rolling. We can do this stuff in the back of the ambulance as well, right? We don't need to be on scene just patients just bleeding away, like, well, we got to get the pelvic binder together. We got to get this together. Everything's not going to be perfect, but let's do our best and let's start transporting, because what's happening in this situation? They're bleeding out, right? So what's better? Get them to the ER at an appropriate amount of time, or put the pelvic binder on before we move them, right? It's risks and benefits. Proper placement of pelvic binder reduces transfusion requirement and the length of stay that the patient is going to have. What the pelvic binder does is, so you have your open book pelvis, it's going to decrease your total space. It's going to bring it back down. It's going to cause a tamponade-like effect. So basically, it's going to bring everything back down. It's going to put more pressure on the vessels right there. So basically, you're doing hemorrhage control just with the pelvic binder, and it's going to help with coagulation and clots being formed. And that's the only reason the bleeding will slow down, if not stop. But what's the definitive treatment for bleeding in the pelvis? Not necessarily surgery. It's interventional radiology, embolization, but basically same thing, right? That's the only way it's going to get fixed. And then once you get the pelvic binder on, you want to minimize any kind of movement, right? Because as we move them, what could happen if you move them too much? Cut another vessel, or the big work we're doing. It's kind of like when we're doing pressure on a bleeding wound. We get curious in 2 minutes, like, oh, let me see if it stopped. Basically, disrupted all the work that you already did, right? So it's gonna start bleeding again. So you want to apply over the greater trochanters, not the iliac crest. So like that little exercise that I only did. You feel the iliac crest. That's not that everybody thinks that's where you want to put it. That's not where you want to put it, right? You want to put it on the greater trochanters. You could use the ones that you're assigned on your ambulances, or if you don't have one, I bet you will do just fine. All right. It's all about the bringing them close together and how much you can cinch it down. All right. Closing the space. You want to leave it in place till you get to the trauma bay. Let us take it off and then do our exam. Just once you got it on, keep it on. Don't take it off, on and off. All right. And then these patients, you want to avoid log rolling. Why would we want to avoid log rolling this patient? Right. So what would you want to do before you put the binder on? Yeah, get it out the way, right? Because let's go ahead and log roll, because things don't happen in just one thing, right? This could be an MVC with a GSW, right? So you still got to do your full primary to make sure you're not missing other life-threatening bleeds. So that's what I'm saying. Don't get distracted by one injury while it could be other things going on. The biggest thing that we see with pelvic binders, or that we tend to do in the field, is we put them too high. Because we think about the hips are up there. We're like, oh man, this is going to get it done. Put them too high. Or too low is not as much. It's mostly too high. But the greater trochanters, as you can see where they are, right there. If you're going to mess up, I say lower is better than high. Because the higher it is, it's really all you're doing is opening up the space down here. You're basically like a bag of chips. If you cinch it up top, the bottom's opening up. That's all you're doing. So the blood is still pooling right down there. It's not really causing any kind of tapping out effect. There are different types of binders. So, like I said, you got your bed sheet, you got whatever that is, and then a regular one. The one that we use, the combat binder in the trauma bay, man, that thing is very puzzling. Once you put it on, it's like a jigsaw. I was like, what are we doing? So, biggest thing is once you put it on, all right, I'll keep going. You want to make sure you cinch it down. All right, you good? All right, you want to cinch it down tight. All right, you want to use. I sometimes use my whole body weight when I'm tightening it. Okay, these are the patients you want to be a little liberal with your pain control, because it's going to hurt. It's going to be painful. One other way that I've seen happen, I've tried to make sure you're getting good placement. Use their foot. Make sure their toes are touching. Like just invert their toes. Make sure their feet are touching. This way you're getting good control of the space that you have in there. We talked about this a little bit. So no log rolling, because the pelvic ring is already an unstable fracture that you have. Your hemorrhage control isn't working. It's going to make bleeding worse. You want to reduce the risk of rotational and translational forces, and any kind of vertical shear or any more injury to any of the vessels. Pain and patient instability. That's why I say you want to control their pain, be a little liberal, because when we're not controlling their pain, it's going to cause a sympathetic response and it's going to cause your heart rate to increase, right? And think about it and visualize your heart rate increasing. What's happening with the vessel with each beat? Pulsating, right? As your blood pressure kind of goes up a little bit too, and you have a vessel that's sheared, think about a hose. If you put more pressure to a hose that's sheared off, you're just causing bigger tear to happen. So that's why control their pain, get ahead of it. These are some images of open book fractures that I've seen. You have, and these are all motor accidents, by the way. See how it's widened right here? Then up here, this is super wide. So you want to put your binder right there and try to close that gap. Think about how much blood is probably going in there, right? And then this is an image that the interventional radiologist will get. As you can see, you have fracture right there, and then you have fracture coming out there, and all of what you see right there is blood. So blood's pouring in there, and that's what they look at, and they try to go embolize that area. This is your wind sweat, like the raw roll injury. You have your fracture right here, fracture right here. That shouldn't be like that, and that shouldn't be like that, right? So these are the injuries. Put a pelvic binder on, control their hypertension, TXA, pain control. Let's start transporting. So pelvic trauma, pretty important, but pretty simple treatment, right? Not much to do. Just make sure you do it right. That's all it is. Now let's talk about extremity trauma. So most extremity trauma is not life-threatening or causes any kind of big limb injury, but the ones that do, you have to be aware of. Pretty straightforward injury to recognize. The biggest problem with limb trauma is you forget to look at everything else because those look so gruesome. You just focus on the limb trauma, not doing your ABCs and not doing your primary because they just look so gruesome, right? Your eyes gonna go towards what looks gruesome, but not what the patient might actually be going on. So make sure don't let that distract you from doing your full exam, physical exam. Serious risks that you can have with extremity trauma, bleeding, of course. You have your damage to your nerves, so you get vascular and neurological injuries. Biggest thing to do with any kind of limb trauma is you want to make sure you always document and feel for a pulse distal to the injury. Ask them, can they wiggle their toes? I did my fingers, but wiggle their toes, move their fingers, any kind of motor function and a sensation. Ask them, hey, do you feel me touching you right here compared to the other side? So you document that like, hey, I did this. They had 2+, 1+, weak pulse or no pulse at all, pale skin, no motor sensation, no sensory sensation, or the other way, normal exam. Different mechanisms of injury that you can have with extremity trauma. So these are going to be your blunt, so falls, direct trauma, so playing baseball, football, direct trauma to the arm. MVC is always penetrating traumas, your gunshot wounds, stabbings, impalements. Complications with these traumas, you get your open fractures, also known as compound fractures, neurovascular injury, and compartment syndrome. This is something we don't think about a lot, but compartment syndrome as well, okay? Assessing extremity trauma, like I just talked about. Check distal pulses, cap refill, sensation, movement, visual deformity, bleeding control is always a priority. The common types of traumas that you're going to see with extremities: bone fractures, joint dislocations, open or penetrating wounds, amputations. This is usually people that are mowing their lawn in their flip-flops, or people that work in factories with heavy machinery. You get degloving and amputation injuries. Strains and muscle strains. So football season's about to start. You're going to probably get calls about this stuff a lot. Dislocations, you're going to get a lot of calls about this. Objects lodged within the limb. So if somebody stabs you and then take the knife out, technically impalement, I guess. Or you fall off at a work site, you get impaled by rebar and stuff like that. Compartment syndrome, serious injury. Always be aware of this. And then crushing forces, so something falling on you. The type of long bone fractures that we have, you have your open compound fracture, connects to the outside. Risk of infection is high. You can have internal and external bleeding with this fracture. Usually often requires urgent or emergent OR for washout and hemorrhagic control. Rapid antibiotics. Do you guys carry antibiotics here? What is it? Recefin or Ancef? Ancef. So these are the patients you want to give Ancef to. Go ahead and give it to them because it's an open injury. It's open to the world. Infection rate is high. Now closed fractures, no outside connection, minimal infection risk. Internal bleeding can still happen, right? This is where compartment syndrome is going to come into effect. What are the 5 big places that you can see blood in when they're bleeding? This might be my own rule, but I want y'all to think about it. Huh? Oh man, that was gonna be my last one. Dang, Wes. Not you though. All right. All right. So the 5 places you have is abdomen, chest. So the abdomen is behind the pelvis, long bones, upper arm, and then he ruined it on the pavement. That's where the most of the blood is going to be from gunshot wounds. You get large amounts of blood loss up to 1 liter in the thigh. So this is called compression syndrome. Compartment syndrome, which is caused by compression, basically. Compartment syndrome and crush injuries, a little similar. This is caused by prolonged pressure on the limbs. You're getting hypoxic, anaerobic metabolism happening. You get a lot of intracellular events are happening. So as there's no blood flowing, you're getting toxins that are building up where the blood is. So when you relieve the pressure, the crush injury, you have a higher incident of having myoglobin, potassium, and lactic acid going into your system all the way. So these will cause you to have rhabdo, hyperkalemia that can lead to arrhythmias, lactic acidosis, which leads to kidney and heart problems. So these are very, keep it back in your mind if some patient's been in a crush injury for a while, that once we get them extracted from the car, from wherever, as the medic, you should be aware of these symptoms, that this could happen. So you be prepared, right? So if this patient goes into arrhythmia, what should you think about? Yeah, right? Why? So they're hyper K, right? So calcium, albuterol. I don't think we carry insulin, but if you have insulin, right? So these are things that you got to think about. Like, okay, this could happen. So let me be prepared for that, right? Rhabdo is just fluids. So I have IV. Let's give them fluids, right? So yeah, mostly. So I don't know if it was a Venezuela or recently there was a big earthquake, either Colombia or Venezuela. I can't remember. So these are the people there you're gonna see a lot of injuries in, mostly, right? Outside of for us, it's mostly gonna be like people at like factories, work-related injuries, or doing something they shouldn't be doing. Like, here, hold my beer. All right. Compartment injuries, right? So this is a surgical emergency, right? This is basically building pressure within the closed fascia, leading to decreased perfusion, tissue ischemia. Biggest indicators, they're going to have severe pain, and they're going to have tingling, numbness. They might also have, I don't know how to say the word properly, but sensation change of cold and hot. It might be cold or like when you touch it with your hand, they'll tell you like, oh, that's hot or that's cold. It's just happening. I think it's poikiloothermia, something like that. Yeah, I just don't like saying that. It's this weird word. You'll have pale skin, so pallor, absence of pulselessness, persistent paresthesias, and a loss of muscle function, right? This is where the pain is going to be out of proportion. When you look at it, it's going to have all of that, but as it's worsening, the pain is going to worsen, but it doesn't look that, like when you touch it, like, why is he so much pain where nothing else is going on? It's because the pressure is building up right there. This is where emergent fasciotomies need to be done to relieve that pressure. We're not doing that in the field unless you're Reef, I guess. He does amputations in the field. But, that's not our job. So compartment-wise, so you got your anterior compartment, you got your deep compartment. So all of the fluid is causing pressure to build in, and it's compressing your vasculature right there. So think about it like a tamponade type effect, right? Then you have your dislocations. We see quite a few of these, and now that football season is about to start up, we're going to see quite a few of these right now. Right? There's biggest concerns for these are neurovascular damage, right? You want to mobilize the joint exactly how you found it and splint it. Now, you want to make sure your PMS is intact. PMS standing for pulse motor sensory, right? If there is a neurovascular injury that you notice and it's dislocated, one gentle tug to get it back in place, right? If it doesn't get back in place, put it in the most comfortable position there is, splint the limb, and get the rolling, right? We don't want to cause ischemia to be in there for too long. So your upper extremity dislocations. So FOOSH, how many of y'all heard of FOOSH? Oh, okay. I thought that was very more. All right. So now we're gonna learn about FOOSH. It's basically fall on an outstretched hand, right? So you're falling forward. You're going to protect yourself, and it's going to cause the injury to go up, and it's going to cause dislocation. Dislocations of your shoulder can happen with sports injuries, seizures, falls, electricity as well. The most common dislocation you have is your anterior dislocation for your shoulder. So I think about it high up, anterior. These are the most common dislocations you're going to have. These patients are going to have their arm slightly abducted, externally rotated. You're going to notice. So when you touch their shoulders and look at their shoulders is going to be flat. There's going to be a little prominent acromion right there, and it's going to be a little step off. And they're going to be holding their shoulder just like this. They would not want to move it unless it's an inferior shoulder dislocation. Then they're going to be just like this. And when you try to bring it down, they will cuss you out, right? So they're going to just hold their shoulder just like this the whole time. Sometimes it happens in MVCs, very rare. But if the patient is just holding their shoulder like that, because that's going to be comfortable for them, think about a inferior shoulder dislocation, all right? Posterior shoulder dislocations. So when we go on a call, like I said, each call isn't just one thing, right? It could be multiple things going on. So don't just anchor on to one thing. You go on a call for a seizure, right? You treat the seizure, you do your seizure stuff, but then don't forget about a shoulder dislocation. Posterior dislocations happen in seizures. Why is that, right? Your deltoid muscle and your lats are pretty strong. And what's happening is that your seizure, they're seizing, and that seizing is causing it to pop out. So complications with these, they're axillary nerve right here. So they're going to have numbness over the deltoid area right here. I mean, they're not going to be able to tell you because they're going to be postictal, but keep in mind, right? You're going to have axillary artery compression. And then once you dislocate it as a young patient, more than likely you're going to dislocate it more than recurrently, oftentimes, all right? Biggest pearl I will give you, do not attempt to reduce the field dislocation in the field. Just immobilize it, put it in a swat, make sure you keep monitoring their pulse, motor, and sensation, especially the axillary nerve. So keep touching them right there, like, hey, do you feel that? Do you still feel that? Is that numb or not? Transport them for x-ray, and then most of these shoulder dislocations, we have to do a procedural sedation. We give them some ketamine, give them some propofol, because it's very painful, unless you're the guy that gets them so often that they just pop it back in, or you're in the football field and it's the fourth quarter and we really need you back. Auburn's got, winning by a touchdown and we got 2 minutes left and need you back in the game because you got to win, bro. So suck it up, Buttercup, But that's very rare, so we're not going to do that in our field, right? No, so just make sure you take good care of them. So that's what's going to look like, right? You have your flattened shoulder, your prominent acromion right there, your humeral head is right there. You're going to feel a little drop off. How many people have seen patients holding an arm like that when they had their shoulder dislocation, right? You could tell shoulder dislocation by just looking at it. Oh, yeah, that thing's out. Another thing you can always ask them, I always ask the patients is, hey, can you use your finger on the side that's affected, the side of your shoulder? They're not going to get past like right here if it's dislocated because of the pain. If they could do that, then I'll start thinking about like a joint sprain or a ligament sprain. Right here you can see, oh, Lord. All right. This dislocated is out of the joint. Out, dislocated, all right? Lower extremity hip dislocation, okay? So these are the ones that we would see if there's no pelvic trauma. So you get hit right on, MVC, people putting their knees to the dash for some reason. For hips, the most common is the posterior dislocation. So shoulder is what? Anterior, hips is posterior, right? Biggest thing you'll notice, their legs gonna be shortened, okay? It's gonna be adducted and internally rotated. You want to check what? PMS, pulse motor sensation, right? Biggest things that happen with hip dislocations is the blood vessels around the femoral neck, right? They get sheared off and you'll get avascular necrosis of the femoral head. And these people, if we don't catch it early enough, if we don't intervene early enough, end up having hip replacements. And then I don't know if you know anybody with hip replacement, that's a whole different world to live with, right? Biggest pearl, stabilize the limb, find it in whatever position you found it, keep monitoring PMS. And these dislocations, it's okay to be a little liberal with pain control, right? You want to control their pain because it's painful, man. Your hip's out of that big old socket. It's gonna hurt. And then transport to whatever appropriate facility that could pop it back in. Fractures. So you have your upper extremity fractures. So the humeral head, you'll see some swelling, shortening of the limb. Could appear angulated. Biggest complication will be radial nerve injury. So they'll have a wrist drop, all right? That little, whatever that guy was, Salt Bay. So it's gonna look like that. Make sure we take into account hypovolemic shock, proximal femur, a lot of vessels going right there. Open fracture, mostly elderly, risk of infection. So make sure we're giving them antibiotics. In these, if there's no PMS, one tug gently. If it doesn't come back, just swat, comfortable position, and bring them in. If it comes back, great. Swat, comfortable position, bring them in. Put them in a splint. Sand splints are great. I like to use sand splints or those inflatable ones, but the inflatable ones take some time. Just sand splint it, bring it in. Lower extremity. This is going to be a very high energy trauma, right? Fall from a decent height, MVC going straight on anterior, anterior kind of accident, intrusion, and then an elderly, just a fall. So I've been burned by this in the ER. This elderly person came in, fall. I was like, all right, I'm not gonna X-ray this person. They just fell. They're moving everything. You gotta image these folks. Had a whole broken shoulder, everything. I was like, oh, all right. I'm glad. I was in training and Dr. Ferguson caught it and told me to image him because I was about like, nah, you be good. Just put in a sprain, little sling, you'll be fine in a couple of days. So elderly, be careful. Their bones are brittle. They are going to break them. All right. So always err on the side of caution. Like I said, lower extremity, you're going to have shortened leg, externally rotated, severe thigh swelling and bruising. So this is where you want to be concerned about compartment syndrome in the thigh, right? That's one of the 5. You've had 1 to 2 liters of bleeding in the thigh. So you always got to be careful. Fat embolism. If you don't get this put in place in an appropriate amount of time, they could get a fat embolism with a long bone fracture, hypovolemic shock. EMS pearl. So I don't know how y'all feel about traction splints. Only time you really want to do it is if it's just a mid-shaft fracture, no ankle, no knee, no hip. I don't know about y'all. I don't know that in the field if they don't have those injuries, right? So what I prefer is a knee mobilizer, right? Try to get it in proper alignment. Make sure you have good pulse, and just immobilize the knee. That's all. That's what we do in the ER, right? You bring a patient into the ER with a traction splint. What's the first thing we do? Take that thing off, right? So just put them in a knee mobilizer and then bring them in. Treat their pain. Get good IV access. Bloods. If you don't have blood and you think they're bleeding, be careful with your fluids. Give them 5. All of us could use a 500 fluid right now. So give them like 500 because if we're just pouring fluids into them when they're bleeding, the numbers may look good. Oh, I feel good. The numbers look good. But in reality, we're causing more damage to the patient, right? Their coagulation is not going to work as well. We're basically causing all the things that work in the favor of the patient to dilute out. Make sure they stay warm. and just monitor them for developing shock. Okay. Lower extremity, tibia fibula fracture. So these you're gonna see a lot of these with sports starting, soccer, football, basketball. These are the ones that look gruesome. Remember Pro Throw back in the day? Man, that man was doing so well till that happened, and he caught it. He caught it too. It was a touchdown. So make sure it's not open or closed. If it's open, infection is a high risk. Compartment syndrome. Control bleeding, direct pressure, tourniquet if needed. Cover the wound with moist, sterile dressing, right? Immobilize. Now, the biggest thing I want to mention, I didn't put a slide in, is if you have a fracture right here in the ankle, what's another physical exam that you need to do? You should do. So if your fibula is broke right there, just shout out an answer. If it's wrong, it's wrong. We'll fix it. Okay. Well, that's always great. Yeah, you're right. So if it's broken right here and it's most likely from an angular, like you sprained it or something like that, you always want to check the fibular head, right? This is a weak part of your knee right there. You check it because this could be fractured as well for some rotational forces. So you always press up there as well, because like I said, don't get distracted just by the injury right here. You know, check up there too, because this happens a lot as well up there. Okay, that's just a pearl I wanted to throw in, because when I was coming up in the as an intern, I didn't know that either, and I never checked it, and I found a lot of injuries up there. Okay. So realign, make sure it's pulse, one gentle touch, rigid or vacuum splints, whatever position they're found in, recheck their, I know I've hammered this, but it's very important, recheck their pulse motor sensation, and frequently, because the complication of neurovascular injury is pretty big. It can happen, right? Especially between the joints, because as you can see in your axilla, you have your brachial artery. Look at all these nerves going through right here. So nerve injury is huge. That could happen. Same thing on your leg, right? Look at all the nerves right there, vessels. Now, if you have a knee dislocation, what should you worry about? Think about the anatomy. Which one? Popliteal, right? So there's a true knee dislocation is when the tibia is either going forward or posterior. Anterior knee dislocation is when the tibia is on the forward side. Posterior is when it's on the back side. Most people will say they have a knee dislocation, but what they had was a patellar dislocation, right? Patellar dislocation is very painful. How do you fix that? Basically, so I've seen this happen. It happens to kids quite a bit. Is as soon as we're trying to get them to move over to our bed, they straighten their legs out, it pops right in. I was like, all right, well, put them back on. Y'all can take them home, right? That's it. But the biggest thing is don't let the popliteal injury go unnoticed, right? You want to immobilize. You want to keep checking their PMS and think about compartment syndrome happening in this. A lot of people might forget about this, but that's all very important. And a lot of the times they might have had a knee replacement. It might have came off. And when you try to reduce it, it's not going to go back in because it's metal rod. And if you're not looking at how to properly get it in, it's not going to go in. So immobilize, check pulses, start rolling. Okay? Amputations. So going to see quite a bit of this in machines, getting your hand caught in machines, trying to clean your lawnmower for some reason while it's running, you know. You get a lot of finger amputations. Biggest thing is apply moist sterile dressing over the wound, secure with elastic bandage. You want to make sure it's even pressure applied around the whole stump. Control the bleeding. Use a tourniquet only if the bleeding isn't stopping, right? How do we preserve amputated limbs? Okay. That man knows something. That man knows something, right? So basically, yes, put it in a saline soap gauze, put it in a bag, then ice. Don't put it on direct ice because If it freezes, it's not going to be viable. Also, chances of reattaching it low, but there's a chance. And if you're in Birmingham, say your transport time is 5 minutes, I wouldn't waste time trying to find ice. Bring them to the ER, and then we'll put them on ice because the hand surgeon's not going to be available there, right? The vascular surgeon's not going to be like just waiting at the ER, like, oh, we got, come, they're going to take their time too. But I wouldn't mess around trying to find ice in the field. If it's a 5-minute transport, 10-minute transport, bring that finger with us, please, or the toe, right? And we'll put it on ice in the ER. Because I don't know how many of y'all are carrying ice with y'all, but just, I wouldn't be wasting time for that. They get up to 6 hours to get that reattached. Impalement. So we see a lot of this, right? Biggest thing, please don't pull it out unless you have to. And if you pull it out, please don't put it back in. This is, I've seen. You pulled out a knife, you got scared, you put it back in. Guess what you just did? You just stabbed the patient, right? So be careful with that, right? Surround the patient, the object with thick protective padding. Keep it stable during transport. Minimize any movement because it's going to just basically cause more damage on the vessels. And then reduce any. Bring them in and tell us what happened, right? If it's open, if you have a long transport time, I'm okay with starting antibiotics on this person because I don't know how clean that knife was. I mean, might have been somebody that's an assassin, so might have been clean, so I don't know. Bleeding. We do this quite a bit. Bleeding control, right? Direct pressure, firm pressure, 2 hands. We do this a lot too. After 2 minutes, you get curious and you relieve the pressure and look at it, and it just comes right at you like, oh man. Be patient, right? Be patient. Keep pressure on there. Don't frequently recheck the wound. Put on a pressure dressing if you have one. Wound packing. If you got clot bandage, put that in there. Hemostatic gauze, there, sterile gauze. If you put a tourniquet on, biggest thing, times, right? Make sure you document the time when you put it on. Wound packing. Why will we not want to pack in the abdomen, chest, or open skull? Exactly. So tension physiology, messing with the lung. Is it really? We're not doing anything. Just put direct pressure on there, right? Why not the abdomen? Yeah. How much are you gonna put in? And are you really causing any kind of tamping out effect? Because the vessel might be a little deeper in, right? So don't put it in the stomach. Why not in the head? Exactly. Brain's in there, and if it needs to swell, it swell. What we're doing is like, no, you need to die faster. So that's what we're doing, right? You stop the bleeding, but we're causing increased intracranial pressure. So make sure you pack just the extremities, okay, and the neck. Hemostatic gauze is always appreciated, and hold direct pressure over it. Now, if you have to use a tourniquet, right, it's really bad bleed, risk of benefits, risk of ischemia, benefit of hemorrhage control. So I'm okay with a little ischemia rather than all their blood end up on the floor, right? 5 centimeters proximal to the injury. So, right, proximal, closer to the body from the injury, I'm sorry, right? 5 centimeters above it, as distal as possible from the injury. That's what I meant. You don't want to put it over 2 bones. Why is that? Why do we not want to put it over here or the tib fib? You can get anything tight if you want to get it tight. But what's going on? What happens between those 2 bones? Huh? Well, it's also vessels between the bones. You can't do nothing about that, right? So you want to go high and tight, cinch it down tight. I would say till, we used to be taught till peripheral pulse is lost. That's fine. Or if the bleed is controlled, like, if it stopped bleeding, all right, we got what we wanted, all right? Recorded times. If the transit is greater than 1 hour, I would say do a trial or tourniquet conversion. So if it's been about an hour, you've had it on, take it off and see if they start bleeding again. Because during that hour, what they're doing is they're getting the coagulation cascade going. Hopefully we get a clot going. So hopefully they don't bleed as much. If they do, we kind of reperfuse a little bit, then put it back. It's not, I won't say take it off, just loosen it, right? Because if we need to, if it's still bleeding, we can tighten it up right away. Less than 1 hour, keep it in place, bring it to us. Make sure you document the times. Okay? So for bleeding control, it's just hemorrhage, pressure, IV blood, if possible, if fluids. Don't be too liberal with it, right? Pain control, very important. TXA, if the injury is less than 3 hours. Greater than 3 hours is no mortality benefit. If the injury has been less than 3 hours, give them TXA. Okay? 2 grams IV or 1 to 2 minutes. So these are Alabama protocols. Check PMS, splint, immobilize. If you're advanced, intermediate, paramedic, or a critical care medic or nurse, you can give them ANSEF or you give them Rocephin, 2 grams IV, IM, 50 mg per kg, IV, IM, up to 2 grams. For massive hemorrhage, if you're an EMT and above, direct pressure, EMT and above, packing, and then we get to consider fluids and blood. It only advanced and above can do that. TXA, only advanced and above can do that. But control the bleed, everybody should be able to control the bleed. Okay? I'm sorry. TXA, everybody, advanced and above. Blood, only paramedic and above can do. All right? I know there was a lot. I know we covered a lot. We've been here for a while. So if you guys have any questions, please feel free to ask me. And what did we check in extremity trauma? There you go. Hey, if not for Anthony. And where do we put the binder? Greater trochanthers. If you're going to mess up, where do you want to mess up at? There you go. All right.
Say mess up at the house.
Oh.
Hey, great lecture, man. Great stuff. I wanted to throw a few things out there. One, in this region, I've been told several times that if you have a patient with a pelvic fracture, you can't transport them unless you have a scoop stretcher.
Mm-mm.
And that's because we don't want to log roll them. What I would argue that you're better off if you don't have a scoop, get them on the stretcher, soft stretcher, whatever you got, get to the hospital. So don't let that deter you. Pelvic fractures can be bad. Takes a lot of force, a lot of bleeding. They should be moving toward the hospital as quick as you can. TXA, I love that stuff. Great stuff. Blood products are great. Remember, if they have pelvic trauma and a head injury, the story of permissive hypotension was all based upon penetrating injury with military young people. So if you got a dude that's in his 50s, riding his motorcycle, that flips it, has got a pelvic fracture and he's altered, you don't want permissive hypotension. You want to get him stabilized as quick as you can. You want to get fluids cooking. You want to do TXA. If you got blood, definitely gets blood products. If he's still hypotensive, talk to your medical director, your offline guy. A little bit of microdose epi may be beneficial for that guy to bridge the gap to save the brain till you get to the hospital and we can get blood. Just food for thought. Tourniquet use, I'd also say that if you got a patient that is critically ill that you look at and you think, holy crap, you're going to die from blood loss. For example, they have polytrauma and one leg's missing, but the leg isn't squirting blood now, but they're sick as dirt. They get a tourniquet on that leg because you don't know if they're just not bleeding because the flow is so low they've already bled out, or it's not bleeding. Does that make sense? So penetrating trauma, if you got a dude that's shot in the leg, one leg's missing, right, and he's got holes in his chest or belly, I get the chest and belly is pretty important, but he's also missing an extremity or has a jacked up extremity, is critically ill. Throw a tourniquet on there, because what we've seen recently is these folks, we start giving them the volume, resuscitate them, and we look down and that ankle wound that was dislocated open is now just pumping. Like, oh, well, crap, that was part of the problem too. So a tourniquet in the greater Birmingham area is not going to hurt anyone for short term, as long as that tourniquet is not placed on the neck, right? Okay.
Y'all laugh. Has happened.
You laugh, but I say things that I've seen.
Yeah.
What else I got? Not much else. That was a great coverage. Any other questions or comments, Chief?
Yeah, great lecture. Thank you, Dr. Saeed. The funny thing to me is that I think pretty much every EMS agency in this area carries traction splints, which I'm like you, Doc. I don't see why we're putting in young, because we can't eliminate the contraindications without imaging. But I really don't, and y'all can correct me in the room. Y'all probably know a lot better than I do. I asked the question online, does anybody carry a commercially produced pelvic binder? And nobody said that they do.
Oh.
Yeah, there are a few places in the region that do carry it. So I've never been a big proponent because they're single use, they're expensive.
Sheets will do just the same
yeah,
job.
the trick to those is, you need to recognize the fact they have a pelvic fracture. So you should be able to pick that up on scene, right? And if you start to do the rock that Doc was talking about, if they start calling you names, you don't have to do any more. That you assume it's a pelvic fracture to prove it otherwise. So it's tough to use those. You know, I would argue. Well, I was going to make a statement about mass trousers, but that'd get me in trouble. So you're right. Not many places carry it, sir.
Yeah, not many places are carrying it. Like you mentioned, Doc, you can sheath. But now, if you don't practice that, and you don't know what you're going to do, I would suggest not doing that on the scene because you're going to spend 25 minutes.
Well, yeah, don't delay transport.
No. Yeah,
And
you
then-
got to get the basics down first, which is the
Exactly.
passive O2, recognizing the injury, initiating IV access for the TXA as you move to the hospital. If you can do all that and start adding in the pelvic binder, great. I think if you're going to spend money, just spend money as a region and work on a whole blood program so you have blood. That's what they really need at that point in the game as
Exactly.
well. And then one other point I wanted to mention, I forgot, was we talk about not packing the scalp, the chest, or the belly, and I agree with that, except there is a population of folks in Alabama that are fairly large, right? And so sometimes you have to look at that patient and go, I get it, you're shot in the abdomen, you're probably bleeding internally, but why is there blood pouring out of that hole? You usually don't get a lot of external bleeding from those wounds. Maybe it's because that adipose tissue there's a big vessel that got dinged by that knife or that gunshot wound or whatever. And you may have to do a little bit of a packing. I'm not saying pull out 40 yards of cling and stick in there, but I'm saying you may have to do a little bit of packing to stop that wound. The other big issue we got is these junctional wounds, like in the neck and in the groin. Those are tough to manage. And sometimes you got to add them. I think a pelvic binder is a great substitute for a junctional tourniquet sometimes, right? So if you got a injury to that groin, you can pack the hole, fingers in the hole, maybe put a bag of fluid over it, and then cinch down a pelvic binder to use that as kind of a compression device. But those injuries are rare, but when they happen, it's tough. Again, the key thing is the basics. Recognize the injury, know they're sick, and start moving towards definitive care. You're doing your oxygenation, you're doing your IV access for your TXA, you're getting close to blood, and you're moving as quick as you can. So those are just challenging wounds.
And then when you're stitching down on the pelvic binder that you made, you can use the windlass technique on that too, just like the tourniquet.
Yeah.
But I mean, if you have time, like I said, don't waste time trying to do all that stuff, but you want it tight.
Yeah, and I think those things are great for junctional wounds too, like we talked about. I think that's probably, in my experience, that's probably more productive to use that for a junctional penetrating injury than for a pelvic fracture because that helps control the bleeding immediately. So.
Very good. Thanks, Dr. Saeed. Thanks, Dr. G and Dr. Ferguson, as always. Great information, great lecture today. And so it all worked out. We had good participation today. Thanks for everybody for joining. Remember to please fill out an attendance form. This gets you your certificate. And even if you don't need a certificate, we would love for you to fill out an attendance form so we can get your feedback. Where are we going to be next time, Dr.?
And we're in Tuscaloosa at Tuscaloosa Fire on the 26th. Please come out. Let's have a good showing there. Even if you don't like Tuscaloosa or Alabama, right? Come out to Tuscaloosa anyway. So let's have a good turnout there. September 24th is a cadaver lab. Don't forget the sim competition. And then the children's people should be here any minute to start the pediatric sim for us today. So Tuscaloosa next time.
Very cool. Look forward to it. Thanks, everybody, and we'll see you at the next event.
Go Blazers.